Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a very hard cataract. Nuclear sclerosis is about grade 5 or even more. Let us observe this surgery. This is the main incision with a 2.8 mm steel keratome at mid-limbus. And now, a side port is made on the left side of the main incision about 3 clock hours away. An air bubble is injected into the anterior chamber. Underneath this air bubble, trypan blue dye is applied over the anterior capsule. Care is taken so that the dye touches all parts of the anterior capsule. Little bit of adrenaline is injected, little bit of phenocane, and now the dye is nicely washed out. In this case, we are going to employ modified soft shell technique. Soft shell technique is you inject dispersive visco, and beneath the dispersive visco you inject cohesive visco. But in modified soft shell technique, we inject dispersive visco from alcohol, that is viscoat. It is a combination of chondroitin sulfate and sodium hyaluronate. Here goes the viscoat from alcohol. Beneath this viscoat, we are going to inject hydroxypropyl methyl cellulose, another dispersive viscoelastic substance. So, this is not the actual modified, this is not the actual soft shell technique, this is a modification of that soft shell technique. However, the chondroitin sulfate that will stick to the corneal endothelium will protect the corneal endothelium till the end of the surgery. A large rhexis is done because this is a hard cataract. A baby-sized rhexis will not work in such hard cataracts. Hydrodissection is done with the help of a 27 gauge cannula and PSS. PSS is injected at multiple points. The nucleus is rotated, and now 2% SPMC is injected again. And now is the time to manage the nucleus, to divide the nucleus into several fragments and emulsify those fragments. The machine being used is Faros from Otley, Switzerland, and the technique that I am going to employ is my technique, Submarine chop, Mohanta's Submarine chop. Some superficial cortical lens matter is removed, the handpiece is turned to make the bevel off, and now the Phaco tip goes into the substance of the nucleus. It travels through the nucleus towards the opposite equator, and as it reaches near the opposite equator, the chopper is used to divide the nucleus into two heminuclei. The nucleus is rotated 180 degree and complete separation of the two heminuclei are done. Each heminucleus is then subdivided into some pieces. In this case, this heminucleus is divided into 3 pieces. Now, each nuclear piece is emulsified. Ultrasonic energy used in this case is 90% in continuous mode. Though the setting is in continuous mode, the ultrasonic energy is being used intermittently. Whenever something is to be emulsified, the ultrasonic energy is used. So, we have to train our foot to do this. This is the other heminucleus. It is being divided into two fragments. And now, this fragment, two fragments are still joined to each other. Here it gets separated and this fragment is emulsified. We are having fairly good red glow. In this case, the microscope is OMS 800 from Topcon. This is the last fragment. At the same time, I am taking special attention for protection of the posterior capsule. Decrease the parameters, go to Phaco 3 mode where the vacuum is 300 and flow rate is 30, and here I further reduce the vacuum, go to 200. Another way to manage this is to use IOL scaffold for the last piece, or we can decrease the vacuum to maximum even 50 millimeter of mercury and manage the last bit of the nucleus. In this case, the vacuum was reduced to 100 millimeter of mercury and this last nuclear fragment is being managed. The chopper has been removed from the anterior chamber for better stability of the anterior chamber. And very slowly, very cautiously, the last bit of the nucleus is emulsified. At this time, we could come out and inject some viscoat behind this piece and emulsify this piece more safely. However, nothing bad has happened. The nucleus has been managed and I removed the handpiece from the anterior chamber. 2% HPMC is injected and a 23 gauge Simcoe cannula is used to remove the cortex. So, the cortex is nicely removed and it is done. The posterior capsule appears very clear, no cells sticking to the posterior capsule. This is a bit of polishing of the posterior capsule by jet of irrigating fluid. The anterior chamber as well as the capsular bag is filled up with 2% hydroxypropyl methyl cellulose. The main wound is enlarged a bit because I am going to use a B cartridge for implantation of the intraocular lens. The intraocular lens is Sensor 1 from Johnson & Johnson, no financial interest. Here goes the lens. The lens is dialed, the haptics are placed little away from the main wound so that we can go behind the intraocular lens and remove visco, that is behind the intraocular lens, that is between the posterior capsule and the intraocular lens. After removing some visco by Simcoe cannula, we are going to use the bimanual irrigation aspiration cannulae. Here goes the bimanual irrigation aspiration cannulae. The irrigation cannulae goes first into the anterior chamber. Irrigation is carried out for some time in the anterior chamber. The lens is dialed. Irrigation and aspiration is used together for better aspiration of the visco molecules. This is a bit of moxifloxacin. Now the side port is closed by hydrating corneal stroma on either side of this stab wound. And now the final lavage of the anterior chamber. At this time, whatever viscoelastic substance sticks to the corneal endothelium is removed by a gentle stream of BSS directed towards the corneal endothelium. The antechamber is nicely formed in this way and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy and great surgical competence.